Hello, my name is Tomas Dobroky. I work at the University Hospital in Bern, Switzerland, and it's a pleasure to be able to give you a talk. On the following topic, I'm going to go into the posterior circulation stroke. So in 2013, several randomized controlled trials have demonstrated that endovascular treatment is not efficacious. So we're kind of faced with a very tough situation. However, those studies did not reflect the real world setting. There was no selection of patients based on imaging, and also patients treated with old standard to reverse were not included. So we were told to stop performing thrombectomies, and we were kind of pulled over. However, luckily, some of our more experienced colleagues did not listen to that and continued, and were able to publish some convincing results. There are 7 randomized controlled trials which were published after that in 2014 and 15, which have clearly demonstrated the benefit of endovascular stroke treatment. So we could keep on going. So I don't want to kind of bore you because you've heard those things over and over. But there's one thing that's important for us for posterior circulation stroke. So all of those studies only included patients in the anterior circulations. None of those included patients in the posterior circulation. So does this powerful tool also work in the basilar occlusion or posterior stroke? Let's start with a nice example. This is a patient last December when I was on call. She came to the hospital at midnight with NIHS 15. We can already see there's diffusion restrictions in the pons and also some smaller diffusion restrictions in the left cerebellum. The angiogram demonstrated a basilar artery occlusion. We see the left vert injection. There's missing opacification of the basilar artery, and there was no antegrade flow from the right vert. We only see some retrograde flow from the contralateral side. We're able to recanalize approximately 2 hours after symptom onset. And so my question for you is, 2 days after that, how would you expect the patient? Would you expect her to be unchanged? Would you think she's in a locked-in syndrome, or she's clinically worse than she was when she came in with NIHS 15? Or do you think she even got better? So what do you think? Well, I have the follow-up here. So this is the TICI-3 recanalization afterwards. And 2 days afterwards, patient got clinically better. She only has an NIHS of 2. And we only see very subtle diffusion restrictions in the anterior part of the pons and a very small diffusion restrictions in the left cerebellum. And a large part of the initially diffusion restricted parts of the pons have normalized. So we have the phenomenon of BVI reversal. So even parts that were previously restricted are not anymore. And her clinical outcome 1 month after was excellent. She presented with an NIHS of 0. So if we look at it, this is one of the most important arteries in our brain, the basilar artery. And in med school, we were taught that this is a very severe clinical situation. And you might end up with something like this, with a severe infarction, or might even die, or it might lead to locked-in syndrome. So how comes in our patient it did not? So you know the concept of penumbra, where collaterals are keeping this region alive. So this is what we're looking here at the anterior circulation, and you all are aware of that. But how about the posterior circulation? So let's go into a little bit more detail there. So we have primary collaterals and secondary collaterals, and we will go through each of those. So the primary collaterals, or the circle of Willis, this is a different patient. It's a It's a male patient with a slight left hemiparesis of this arteria with an NIHS of 2. And when we do the angiogram, he has an occluded basilar artery just distal to the ICA origin. But he only has this very small infarct region here in the pons. So how comes? If we look at the injections from the right ICA, we see that the basilar tip and the posterior cerebral artery and the SCA are being perfused from the P.Con, and those are keeping the entire upper brain stem and upper cerebellum alive. So basically, he's only suffering from deep perforator infarcts at the arteries originating at this level. Otherwise, all other arteries are open. So what about other collaterals? We have the leptomeningo collaterals. I'm very well aware that you all know them. This is a patient in the upper row and the lower row, two different patients. In the early arterial phase, the image looks very similar, also in the lateral projections. However, when we look into the later phase, we see that in the upper row, there is poor collateral filling, and in the lower row, we see the excellent filling of M3, even M2 branches. We see here in the lateral even better that there is excellent collateral flow supplying most of those MCA branches. And that's the concept of collaterals and fast and poor, slow progressors. So patients with poor collaterals might suffer a very large infarct volume even within a very short time, whereas patients with good or excellent collaterals are keeping up the penumbra alive and might benefit from later revascularization. So that's the concept of those trials that I'm sure you're aware of. How about the collaterals in the posterior circulation? Yes, there are some of those leptomeningeal collaterals. So in this case of basilar artery occlusion, we see that there's retrograde filling of the superior cerebellar artery, and there's even retrograde filling of some perforators that actually originate from the basilar top. So this is all retrograde filling, and we see an excellent blush of the entire cerebellum. What about the superficial brainstem, or are there any collateral networks? So we might want to compare this to the spinal cord. Lajonias and his colleagues described that there is a very big similarity in those anatomies. So if we would consider the anterior spinal artery, the basilar artery could be an extension of that. And if we look at this anatomic image, we have interconnecting arteries connecting the segmental arteries, and this whole concept is the spine vasocorona. We have something very similar in our brainstem, and I'll demonstrate you some images in the next slide. So when we look at a patient, this is a high resolution angiogram DynaCT patient with a high-grade stenosis of the basilar artery, and we see those perforators running on the superficial side of the brainstem, and there are small interconnecting arteries that are connecting each segmental level. And this is something we see here in this patient with a basilar artery occlusion, where not only the arteries that are originating at the level of the lower basilar artery, but there are also the perforators higher up, which are supplied by collaterals. And there are perforators, just like in anterior circulation, when perforating arteries or end arteries are occluded, just like in M1 occlusions, the patients usually suffer basal ganglia infarction. And this is due to the fact that these are end arteries. The same applies for the posterior circulation, where deep perforating branches originating from the basilar artery are responsible for the brainstem. And if the basilar artery gets occluded at a segment, those deep perforating arteries have no collateral supply. This is a very unfortunate case, which demonstrates the importance of those end arteries, the deep perforators. This is a patient with a basilar artery vasculitis. We see that in the angiogram there is a lack of filling of those perforating arteries. In the later stage, a couple of days later, we see the severe irregularities, and the MRI demonstrates the extensive infarction and hemorrhagic transformation, because all of those end arteries, the deep perforating arteries, have occluded. So it's important to take an anatomy in count, and we need to be aware of those collateral pathways and also of the end arteries. So let's go in a little bit more into detail on the anterior versus posterior technical aspects, and also on some studies. So some authors argue that the clot that gets stuck in the basilar artery might be pushed back and forth, because the wave flow coming from the basilar artery might push the clot a little bit cranial, whereas the flow from the P.Con might push it down. So the clot is being pushed back and forth, which enables the perfusion of some of those perforating arteries, keeping the brainstem alive. So this is a concept that is proposed and might lead to an extended time window, keeping those collaterals or the perforators open. So overall, the stroke in the vertebral basilar system is rare. It only accounts for 5% of large vessel occlusions. However, it can have a very devastating outcome, because up to 90% or even higher rates of mortality have been reported in patients that have not been treated. The clinical presentation is highly variable, ranging from very mild symptoms such as isolated cranial nerve deficits, dysarthria, vertigo, however, up to locked-in syndrome, coma, or even death. How or where do those occlusions occur? So if you look at the basilar artery, about 20% are found in the distal portion, in the basilar tip, and mid-basilar about 30%, proximal occlusion about 50%. If we see a mid-basilar or proximal occlusion, we also should think about the underlying stenosis, because usually a clot that's coming from the vertebral artery gets washed up into the basilar tip. However, when it gets stuck at the lower level, sometimes there can be an underlying stenosis, or just as in this case, patient after recanalization realized the reason for the clot being stuck at the mid-basilar. This was a fenestration. So, like mentioned, there is a high degree of underlying stenosis, higher than in the anterior circulation. This might be even something you are more aware of in the Asian population. And also important to keep in mind that there is a lot of time we can encounter a tandem lesion, so a occlusion or a stenosis at the origin of the vertebral artery. There are different scores that might be used. There is the posterior circulation aspect, which are, in our case, are not used as frequently in clinical practice. How about the approach? How do we approach those occlusions? Just like in anterior circulation, you notice this graph from Riedel, who demonstrated that the larger the clot, the less likely it is to recanalize with IVTPA. Do we have similar supporting data for the posterior circulation? Yes, we do. This is a study from P.An who demonstrated that in patients with basilar artery occlusions who with small clots, they are the likelihood of recanalization under RTPA is higher, whereas in larger clots, this number decreases. Overall, the same may be applied for the anterior circulation as posterior circulation. In ICA M1 occlusions in patients under IVTPA, the rate of recanalization overall is low. The same applies for basilar artery occlusions, whereas patients with peripheral occlusions, the recanalization is higher, especially in patients, the drip and chip patients, which have a longer time for the IVTPA to do its work, and maybe the longer, the bumpier the road, the better it may work. So overall, for peripheral occlusions, smaller branches in the posterior circulation, looking at ICA, SCA, or PICA, the IVTPA is a very good tool however, when looking at large vessels, in our case, the basilar and maybe the vertebral, when it's the only one that's supplying the brainstem, the endovascular treatment is a very good option. Looking at some studies, this is the Beyond Swift registry, who compared patients with a basilar artery occlusion and anterior circulation large vessel occlusions, demonstrated no significant difference in favorable outcome between both groups. Like mentioned previously, intracranial stents were used more often due to the underlying stenosis. Overall, the outcome is pretty good for the endovascular treatment. This is a large meta-analysis demonstrating a significantly improved clinical outcome, increased recanalization rates, and decreased mortality in patients undergoing standard retriever thrombectomy in basilar artery occlusions. Do we have randomized controlled trials, just like the ones I mentioned in the beginning of my presentations? Yes, we do. There are some caveats, however. This is one study including patients within a 6-hour time window, comparing endovascular treatment to standard medical care, and the primary outcome was the favorable functional outcome MRS 0 to 3. The authors reported there was no significant difference between endovascular therapy and best medical care. However, it is important to mention that almost 1/3 of patients were treated outside of the trial, so they were screened. However, they were not included in the trial, and most of those patients received endovascular therapy. So this is the basic trial. There is another randomized controlled trial. The BEST trial is a trial from China. They screened almost 300 patients. Out of those, 131 patients were randomly assigned. And the study was terminated early because of a high crossover rate and poor recruitment rate. The authors conclude that there is no difference in favorable outcome at 90 days in the intention to treat analysis. However, when we look in the as treated analysis, there is definitely a better or a favorable outcome favoring endovascular treatment. So we already kind of see the issue here with the randomized controlled trials, poor recruitment, high crossover rates, patients that are screened and are not included. And this might be mainly due to the fact that there is kind of an ethical dilemma to include a patient to a therapy where you're kind of really believe or convinced is less efficacious. So not submitting a patient with a basilar artery occlusion to endovascular treatment, which might be an important bias in those randomized controlled trials. So the endovascular treatment has been started very early on. This is one of the first images I found at our institution. This is from December 7th, 2000. One of our former chair, Professor Schroed, already back in those days performing aspiration procedures and aspirating those clots like demonstrated here. Some technical aspects when looking at those clots. Where is the clot? How do we approach it? We can either go up the dirty way, so the underlying stenosis or occlusion of the vertebral artery, in case the other side is hypoplastic or there is no other vertebral artery, or if the vertebral artery with the stenosis, harboring the stenosis, is hemodynamically not relevant, we might go up the clean pathway and tackle the clot from the clean vertebral artery. So just like in anterior circulation stroke, standard retriever, aspiration, whatever you feel more comfortable with, there are good results with both. Can we use balloon guide catheters? It might make sense in some situations, like here, there's a large thrombus at the origin of the left vertebral artery. And here using a 9 French Mercy balloon, which was inflated in the subclavian artery while passing the thrombus and performing the thrombectomy here. I think we did do aspiration on this clot and then thrombectomy of the basilar artery occlusion. And then one caveat, like mentioned, underlying stenosis. So a lot of times we're faced with the situation that after thrombectomy, the vessel closes on us again very, very shortly after thrombectomy. A lot of times we add aspirin, however, it keeps recurring or it keeps closing again. So then we're kind of faced with a difficult situation because we're forced to do a angioplasty or place a stent. However, both the angioplasty, you might expose the plaque that might be thrombogenic, or the stent adding more foreign body to an already very thrombogenic situation, which then requires anti-thrombotic treatment, or and this has not been established the best way how to go for that. And there is a large, very big difference between centers. We previously applied RioPro. Now our standard procedure is usually started with aspirin and integralin, a bolus, and a perfusion dose of integralin. Some centers start with Cangrelor, but there's a large difference between centers. So in conclusion, the posterior circulation stroke works very fine for endovascular treatment. There might be it's important to remember the extended time window, because the prognosis overall is very poor when left untreated. Because of the mechanism of the clot being back and forth, maybe this is a explanation why the perforators are being kept for a longer time, and there might be even some DWI reversible lesions. It is important then that to remember that there is a higher rate of underlying stenosis or tandem lesions of the proximal vertebral artery, which might make the access and treatment more challenging. The randomized controlled trials that have been performed so far on the subject are kind of disappointing, but like mentioned before, there are certain ethical and methodical aspects to those studies that are important to keep in mind, and this should not lead to withholding mechanical thrombectomy to those patients. So thank you very much. I appreciate the opportunity, and hope to meet you sometimes in person. Bye-bye.